All right. Well, welcome today to today's Lunch and Learn from ARPA. We have Dr. Lauren Quetsch with us today. She is a clinical psychologist and assistant professor, soon to be associate professor at the University of Arkansas in the Department of Psychological Sciences. She received her PhD in clinical psychology with a specialization in children and families from West Virginia University in Morgantown. Her research and clinical interest focuses on providing treatments for autistic youth and families. And her topic today is conducting evidence-based family-centered treatments with autistic youth, protocols, co-occurring conditions, and lessons learned. So very excited to hear this presentation. I want to remind people, stay muted during Lauren's presentation, but unmute to talk and ask questions. And we're kind of hoping that be a little bit more conversational today. Okay.
Yeah,
Yeah.
thank you. I appreciate the introduction. I'm going to share my slides and then we'll get started. All
Yes, we're
right.
good.
Yay. Okay, wonderful. Thanks, everyone. So I'm going to be talking a little bit about my work with autistic youth and some of the family focused treatments that I've been doing in my practice as well as with research. But I'm happy to answer any questions that people have about some of the work I've been doing. So I know that Dr. Whiteside already gave me a lovely introduction. But I am a licensed clinical psychologist. I work in a couple different places. So my main home is the University of Arkansas in Fayetteville. I do research, I teach, I have some service responsibilities there. And in addition to that, I am now working just one day a week at the University of Arkansas for Medical Sciences, where I provide clinical services there. So we have a clinic at the University of Arkansas as well where I supervise graduate students, but I do face-to-face service or face-to-face clinical work at UAMS with sometimes with graduate student help, but where I'm delivering the interventions, yeah, on part of my time. So these are based off of my training, but in some of my research as well as that direct care that I'm providing. So, the reason that I wanted to present on this topic today is because there is a massive growing prevalence of youth that are being diagnosed on the autism spectrum. And so, the latest statistics that have been provided from the Center of Disease Control are saying about 1 in 36 children are now diagnosed. And so, because of this, there's a growing need for care. I think this increased awareness this expanded diagnostic criteria, and family seeking help earlier on has really increased the demand substantially for care for autistic youth and their families. So, if you don't think you've met an autistic person yet or cared for them, the likelihood is you probably have, and maybe they were undiagnosed. So the thing about it though is a lot of the services that are available and often recommended for autistic youth have to do more with their functioning within the community. I'm thinking of applied behavior analysis is usually the first thing that's recommended for autistic youth that are diagnosed. So there are all sorts of things that can be addressed in ABA therapy, but usually it's individual centered. So a therapist is working directly with that child on particular skills. Additionally, they might be recommended for occupational therapy, physical therapy, speech language therapy. But again, it's that child working directly with the interventionist to acquire particular skills so that they can increase their ability to sort of function daily within society. So instead, what I really focus on is family-based services. And the idea here is that there's a lot of families, and research has suggested this too, especially our autistic families of color, are really desiring more family-based treatments. But A, these opportunities for care are limited, and B, there's not always a great recognition of other providers about the utility in this care or the fact that maybe families even want this. So not always being recommended as a first line intervention as some of those other interventions are. So for example, some of the research that we've seen and been a part of is, we have more families, more white families potentially of autistic youth that are recommended for family-based care. But even though our families of color really want these family-based options, these aren't always recommended to them at the same rates as like our white families. So something to be thoughtful about how important this is and how a lot of families are really desiring these services, but not necessarily getting access to them. So I'm going to talk about a few evidence-based treatments today. Why these in particular? Mostly because this is what I do. There's some other interventions, family-based interventions that exist, but these have a lot of great research support behind them. I'm going to talk a little bit about some treatments that were originally created for neurotypical youth and then have been adapted for autistic youth. And then I'm going to talk about a few interventions that were created with autistic youth as those that are receiving the intervention directly. So it was kind of conceptualized as that was the population that was going to be reached. So we'll talk about each of these, and feel free if you've got any questions or anything, feel free to hop in and ask about them. I'm more than happy to talk about it. So the first one that I'm going to talk about today is trauma-focused cognitive behavior therapy. So this is an intervention for children, but usually between the ages of 3 and 18. There's been some research to suggest that it can also be effective for adults too, but really this was created for children who have experienced a trauma. And so that can be one traumatic event or multiple over time. And usually the idea is that it's a clearly defined trauma exposure. So as the therapist, the goal of this is to work on different skills with that child, but gradually expose them to the trauma that they have experienced, because there's a stigma associated with it. These youth are usually have PTSD symptoms. People aren't talking to them about it. And so they're kind of handling it on their own and they're experiencing a lot of negative symptoms related to it. There's some research to suggest that TF-CBT can be effective in as little as 12 sessions, but it can go beyond that and it might vary depending on the needs of the family and depending on the how often the family's coming to session too. That can sometimes be a barrier. The idea is that it includes the child and a non-offending or safe caregiver. So I've done this before with, a biological caregiver. I've done this before with like a step parent, foster parents, and just anyone that's a primary caregiver in that child's life, but not an offending caregiver. The focus of this intervention is a lot of psychoeducation related to trauma, incorporation of skills related to relaxation, better identifying emotional experiences. And can be challenging for autistic youth. Sometimes the connection between what my body is doing and what that means isn't always as easy for autistic children. And so having conversations about that and having them be better able to identify what they're feeling is really important. And then you have some skills related to our cognitive triangle, helping them understand how these behaviors, feelings, and thoughts are all connected, and then processing the trauma over time. And then there's some additional components that you can focus on, such as exposures, if there's still some lingering concerns related to a trauma after you've gone through like a trauma narrative. But the cool thing about this intervention is you work with the child directly. So therapist, child works together. And then part of that session is the therapist and parent or that other caregiver are working together as well. And then at the end of the trauma narrative, you bring everybody together in a session and you allow that child to share their trauma narrative. So the idea is that you've got a supportive group, you've got a parent that is supporting that child as they're starting to implement some of these skills throughout the duration of this intervention. And then they come together at the end so that child has someone safe that they can share their trauma experience with.
Lauren, I have a question about
Yes, please.
TF-CBT more specifically. So you had mentioned that this one works best with a clearly defined trauma exposure. Is
Mhm.
it also effective for our kiddos that have like early homelessness or changes in caregivers where it's a lot more like chronic or developmental trauma rather than a single
Yeah.
traumatic experience?
Yeah, I think it can be. I know that the tricky thing sometimes that clinicians will ask is like, what if they've had chronic trauma and it's not necessarily one event? I think usually you still kind of focus on a very salient event, even if it's been prolonged, but you're also incorporating those skills continuously with potentially more than just one trauma exposure. So yes, I think it can be effective. I think that the real issue is when someone's like, I think the kid experienced a trauma, but we don't know what it is. Because as a clinician, your goal is really to gradually expose them to it. So we're talking about relaxation strategies or, identifying emotions. And you might say something along the lines of, I bet you felt really anxious when insert trauma, right? So it's like you are incorporating the discussion of it throughout the course of the intervention, not just waiting until the trauma narrative. So that's where it becomes hard is when someone says, "Oh, this kid I think had a trauma, but we don't know what." Because as a clinician, you can't really expose them to a trauma or talk about it with them if you don't even know what it is. So, yes, that's really the only concern. But if they've had multiple or prolonged, as long as it's clearly defined, we know what it is. And sometimes even talking about it generally, kids will share more over time too. But yeah, you could definitely do that. That's a great question. So yeah, that's TF-CBT, really effective. And I'll talk a little bit more about some of the ways that I've adapted it with autistic kids. But originally, this is an intervention that was focused for neurotypical kids, not necessarily identifying autistic kids as like the target population, but we can definitely tailor it and it works really well with our kids. Okay, let's see. So the next one I'm going to talk about is parent-child interaction therapy. This is an evidence-based intervention as well for children between the ages of 2 and 7 with disruptive, or sometimes that means aggressive or non-compliant behavior. The cool thing about PCIT is that there are also adaptations for kids that are younger as well as kids that are older. And this is really useful when working with autistic kids as sometimes you get a 3-year-old or a 4-year-old even that comes into the clinic, and technically they are within our age range, but they're functioning a little bit lower. So maybe they're not speaking. Maybe we're not entirely sure if they understand. Hey, if you do this disruptive behavior, then there's going to be a consequence for it. If we're not 100% sure that they understand that those things are linked, their behavior is linked with some sort of consequence, then we may not do that sort of standard protocol, but we might adapt it for those younger kiddos in the way that we go through it. Also, it can work with older kids too, just being thoughtful about what does that child understand, what are their capacities, and also what are their caregivers' capacities. So the idea here, what's really cool about PCIT and unique is that as a therapist, I'm not ever in the room with the family really. I might check in with them at the beginning and check in with them at the end, but generally I am not the one who's actually delivering the intervention. The caregiver is. And so what's happening is the caregiver is playing with their child in a room. They have a Bluetooth device in their ear, and I'm coaching them in the other room. So there's a one-way mirror where I can see what they're doing, but they can't see me. And I am coaching the caregiver on how to respond to that child's behavior in the moment. So the first phase of this intervention is focused on building a better parent-child relationship, and that's called child-directed interaction. And then in that second phase, we're working on the parent providing a consistent, structured discipline strategy where we say something, we expect the child to listen and to comply, and then if that's not happening, we have that structured procedure. So PCIT has been, it greatly varies on how long you can do the intervention for. Some families just blow right through it, which is great. Other families, it takes a little bit longer. I've just noticed that depending on the needs of the family and, the amount of stress that the family is under, that kind of can determine how long the intervention takes. But the focus of this is really initially building a stronger parent-child relationship and understanding. And there's a lot of times that caregivers come in and they've got a good relationship with their child, but they don't really know how to connect. So it feels very much like I'm giving to my child, or I think I'm doing the right things, but unintentionally I'm reinforcing problematic behavior that my child is having, or I'm trying to enforce some sort of rule, but actually this is not a developmentally appropriate expectation for my child. So getting them on the same level as their kid. So we work on what we call the PRIDE skills, which is just an acronym for the different skills that we focus on to enhance that relationship. So that's praise, reflection, imitation, description, and enjoyment. And then, like I mentioned in the second phase of the intervention, once they've hit the goal criteria for the first phase, where they are interacting with their child in a positive way, they're hitting these skills at high rates, then we can move on to that second phase of the intervention. And the discipline procedure is a timeout procedure that we go through. And so it's always a little bit of an interesting experience to figure out how our autistic kids might need the procedure modified a little bit. For example, sometimes we have kids that also have ADHD, and even when they're the happiest little versions of themselves, they are not sitting for a very long period of time. So that maybe we need to think about like, well, timeout, and expecting them to sit for 3 whole minutes is unlikely because they can't do that when they're very happy and trying to play anyway. So maybe we modify it that way. I've had some kids that are really big and really intense and aggressive. And so having a parent, usually procedure involves like that parent picking up the child and moving them to another part of the room or to a safe space. Sometimes with those bigger kids, we can't do that. Or if the parent has a disability where they can't pick up their child, then we have to problem solve in that way too. So those are just some examples of things that we've modified along the way as well. But any questions about PCIT?
I think I have a question mostly about like providers of PCIT. I know that there are few and far between in Arkansas.
Mhm.
My assumption is a traditionally trained PCIT provider probably doesn't have as much experience with adapting it to autistic youth.
Yeah.
Is there a workaround for that, or is there a way to?
Yeah, that's a great question. So PCIT International, so the organization that, gives people their credentials and does all of that. There have been some researchers and folks that have worked with autistic youth that have done like some trainings in the past, but there's not really that structure now. So my lab is working on creating a protocol, and the goal will be that we can publish it and train folks on it over time. We're doing some pilot testing of this particular protocol in a group-based setting as well as individual-based intervention. So the goal will be that we provide that. If anyone does this work and wants consultation, like I'm more than happy to chat about it. I think that's one of the biggest issues about providing family-based interventions is there's people that just don't feel comfortable or confident working with autistic populations. But there are ways to do it, and PCIT can be really successful with kids that have like low support needs, for example. Like you can just do the protocol regardless of the child's diagnosis. But in other cases, you have to be more thoughtful about how to adapt and modify. So I'm happy to talk with people too if they've got questions about it. But yeah, I think that's one of the bigger issues. For if anyone is looking for PCIT providers in general, though, there is the ArBest website that's associated with UAMS. You can just go look ArBest PCIT providers, and you can search by city, county, and they will show you everyone that's been certified through the ArPA's system. So they provide free trainings for folks. Or maybe you're a provider and you're like, I would love to be trained in PCIT. They provide free trainings, which is amazing. ArPA's gets funded through, I think, the alcohol sales tax in the state. So if you're a provider who's curious about starting this intervention, then you can get trained by ArPA's. So plug for them because they really are a fantastic organization. Yeah.
I've got a I've got a question. I mean, I see some really more severely severe kids. I mean, be it either that they are developmentally severely delayed or
Mm.
just the autism is a level 3. I mean, they're aloof, they're in their own little world. There's lots of say there are not even any play skills there. I mean, it's pretty much pouring out and or some self-stimulatory sensory seeking behaviors. So just I'm somewhat familiar with PCIT, even though I'm not a qualified provider.
Mhm.
But have you seen that? I mean, I cannot imagine how even the first sequences, the play skills, mom saying, commenting on how the child is playing, that would even be sinking in.
Mm.
Do you have, I mean, they don't even, I mean, they are nonverbal, or at least the speech is echolalic,
Mhm.
repetitive. So have you any experience there? Is that something that you still believe would work?
I think so. I think that there's another thing to think about too is the one of the other interventions that I'm going to talk about is Ruby. And so if it makes more sense to do something like PCIT versus Ruby. But yes, we've worked with kids that are non-speaking before. We've worked with kids that are, and when I say we, it's me and my graduate students that provide these interventions as well. And kids that you're not always 100% sure if they're hearing or comprehending what's being said. I think the wonderful thing about PCIT, regardless of, the level of support that the child needs, is it just teaches the parent how to be present with their child and engage in activities that even though they don't seem like they're playing, you can get the parent to like be on the same level as that child. And when you do that, it's sort of like their worlds connect more than what it feels like previously. I think parents are so that with all the interventions that their kids can have or can be exposed to, they're trained to be like teachers. So they think every moment that they're supposed to spend with their kid is, well, I have to teach my kid how to brush their teeth or tolerate taking a shower or tying their shoes. And they forget like how to just be a parent and be present. So I think it's good skills regardless. And we've had success. We've had kids that we've seen before where the child really loved math. And so the parent was like, how do I engage with my kid? And we made math fun. Like we made math play, right? And we've also encouraged parents to just get on the floor with their kid that maybe loves to spin the wheels on a car, and you're just sitting and you're spinning the wheels on the car with that child, and they just connect better. They sit with them, and sometimes parents are like, I don't know what I'm doing, but here we are. And we found it to be
So,
successful in that way.
so a little bit like the floor time approach.
Yeah. So PCIT has a lot of other theoretical frameworks that it pulls from, but yes, there's floor times one of those interventions that it's pulled uh some theoretical backing for it. So it's all via play, right? Like you are with your kid, you're interacting at their level. And that's a great way, at least especially to start. And then if we've tried to like be flexible and play over time, depending on that, if we're trying to encourage like friendships with peers and how do we make sure that, you know, we're being flexible. If a kid wants to come over and play with something, we're not just like knocking them in the head with that toy. So we have increasing flexibility and allowing for play to look different too and stuff as well.
Okay, thank you.
Yeah. All right. Well, I'll go on. Feel free to hop in with more questions though. Okay, so the next intervention I'm going to talk about is facing your fears. So this is for a little bit older autistic youth that have like co-occurring anxiety. So you can do it in an individually based or group-based models. I've done both. and includes both the child and the caregiver. There are 15 sessions, structured sessions that you can do. It, again, you can be flexible. And sometimes I found with working with autistic kids, it's like you've got one game plan and then something else arises and you're like, all right, I'm going to use this intervention, but I'm going to shift over here for a minute. Sometimes that's how I feel with PCIT. It's like I start with PCIT and then we have to shift a little bit more to more like autism psychoeducation and sometimes Ruby, which I'll talk about in a second. And then we shift back. So it's a little bit of like you're being flexible in some of these ways, just depending on the needs of the family. But the idea with facing your fears is you're identifying anxiety and figuring out what makes a child anxious. You're helping them acknowledge what does it feel to be anxious? What control do I have over these things? How does my body feel is an important component of it. We use child-friendly terminology like worry bugs. And then how do we handle our anxiety? So I think for autistic kids, maybe they're not even realizing they're anxious, but they're having these big reactions and it can look like defiance, but maybe it's actually driven by anxiety. So how do we help these kids manage that in an effective way or a more functional way than like hiding under the table in the cafeteria, for example, or other things that I've heard our kids do. So understanding what anxieties are, I mean, it's very similar for those folks that have done evidence-based exposures for any type of anxiety or phobias, where you have a fear hierarchy and a ladder, and then you're working with the kids to address those things over time and build bravery. And then also just being thoughtful about that long-term maintenance as well. So facing your fears, it can be done in a group, it can be done individually, but again, it's family-based. You're incorporating the child as well as the caregiver in that implementation. Okay. And then the last intervention I'm going to talk about is Ruby parent training. So this is for autistic kids between the ages of 3 and 12 with problem behaviors. It doesn't necessarily have to be aggression or defiance, but that can also be included. This is really focused on the caregiver themselves. So the child is not necessarily involved in the actual intervention. You are working with the caregiver to give them skills about how to better understand their autistic child and managing behavior. And there's a lot of feedback related to like how it's going with the kid, but not necessarily having that kid attend the sessions, right, with the caregiver. So there's some core sessions, there's some supplemental sessions, just depending on other things that might be going on. Not all autistic kids have issues with toileting, which we'll talk about in a minute, but they could. And so Ruby might talk about that specifically for a family that has those issues. So for Ruby, the idea here is that you're really helping the parent understand, what is autism? What are your needs of your autistic child? And then what does a behavior mean? So what's happening with the behavior? What's happening before and after? So for those familiar with like the ABCs of behavior, those are the antecedents, the behavior, and then the consequences. So understanding why is a behavior continuing, right? What are the sort of vulnerabilities or the situations that increase the likelihood of behavior? And also, what are the consequences that are happening afterwards that are allowing that behavior to continue? So helping sort of think in a more scientific way about something's happening and what do we have control over, or how do we modify this behavior over time? And so thinking about how do we prevent behaviors, that would be more of like your antecedents. How do we structure the environment in a certain way so that we're not having those behaviors as frequently? And some of those things might be related to like an autistic kid is having sensory sensitivities to certain situations. And it's not just defiance, right? It is, I am overwhelmed by my environment. So are there things that we can do ahead of time that allow that child to better manage so it's less likely that they're having these big explosive meltdowns because they're feeling overwhelmed? Daily schedules. So how do we create routine? Our autistic kids love routine. How do we make sure that we're having some routine? And we might need to be able to increase flexibility, but if we're feeling like our day-to-day does not have any structure, then that can increase the likelihood that you're going to see more of these problem behaviors. How do we increase and reinforce behaviors that we want to see? How do we provide attention to the good things we want to see and not give attention to the things we don't want to see, so decrease the likelihood of that behavior? How do we get kids to listen and follow instructions? And then how do we increase functional communication, not just for the kid, but for the parent as well? So how do we communicate the things that we want to our children, and how can we allow them to communicate better so everybody's kind of on the same page? So Ruby, could take 11 sessions. It could take more. And depending on sort of the issues that arise, you could add other components to the model to address some of those things. Any questions about Ruby or anything? Okay. All
Is
right.
Well,
there
Lauren, I actually do
Oh,
have
yeah.
oh,
Yeah, go
sorry,
ahead.
just a quick question. Is that a way you can access that? Is that like, or is that something you have to purchase, like a manual?
that was my question.
There's a manual. Yeah. Yes, you can purchase that. I did an online training too, which was pretty accessible. I don't know how many years ago it was now, but I'm not aware of like how frequently they do these trainings. But if you've got some exposure to autistic youth, I think it feels not too challenging to read the manual and understand. If you are like, I've never worked with autistic youth, it's a great sort of starter package to think about how to do that as well. I took the training. I have some materials if people have questions about it too. But yes, you can purchase materials, and they actually what's really nice is you can go to the Ruby website, and they do have some handouts and other things that are just freely available on the website. So you can purchase the manual, but also there's some supplemental forms and stuff that just exist there too. But yeah. Someone else have a question?
Yeah, I think Dr. Falls, you said you had a
Yeah.
question. I think it was, yeah. Go ahead.
No, it was your question. I was
Okay, great.
wondering if there's a manual, if that's something, that you can, oftentimes, these parents, they come, they're under a lot of stress. They just need some immediate something they can do. They
Mhm.
and so having something that has a limited time where you say, okay, we schedule 11 sessions, would be helpful also to get the commitment, and
Mhm.
not like, okay, this is not gonna go on
Forever.
forever.
Yes,
And
yes.
and but also then if you are a therapist that has a basic understanding of behavior modification
Mhm.
and a basic understanding of autism,
Mhm.
is it possible to just use the manual and apply it, or do you have to do a specific
I think so. I
expensive
honestly,
training?
yeah. No, I feel like there's for something like PCIT, I would not say that should just go out and
Exactly.
try
No,
it.
it's
Like it's
complex. It's
it's
very
it's so
complex.
complicated, but Ruby is a lot feels a lot simpler and more attainable without like an intensive training. So, yes, I think so. I think people could do it. But if people have questions or are trying to integrate it and want to contact me too, like I'm happy to chat with anybody about it.
Mm.
So I really like Ruby as well. It's a great, and that's as I mentioned before, sometimes I fluctuate between like I'm doing PCIT and it's like, all right, we need a beat to like maybe cover some Ruby skills that aren't inherently part of PCIT. And then okay, we feel like we've got some of these things under control. Okay, let's go back to PCIT. So sometimes I'll have like parent only sessions where we talk about some of these skills for parents of autistic kids. So
What I also experience, and maybe that's just I cannot communicate it well enough, but when I use elements of PCIT here and there, parents are often not patient. They want to get to the
oh
how do
yeah.
I deal. They come because they already have been a year of behavior problems. The kid got kicked out of school. They don't want to spend like 10 sessions just to play. I mean, okay, now when do I get to the helpful stuff? What am
Yeah.
I going to do? So do you have any experience or any advice how to handle that? And does it
Yeah.
happen, or does it just happen to me?
Yeah. No, 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 no. That definitely happens. Sometimes what I tell caregivers, I give them the analogy of like good versus bad boss. So the first question I'll ask is, okay, tell me all the characteristics of a good boss that you've worked for, right? So tell me what they did, how they made you feel, right? Sort of give a laundry list. Now tell me about a bad boss you worked for, and what did that feel like? What were some of the experiences with that individual person, right? Now, when your good boss or your bad boss asks you to stay late or do something on a tight deadline or something like that, which one were you more likely to want to assist with, right? And most will say the good boss, right? Or I get really mad at the bad boss, or I was just, that's why I quit, etc., right? So sometimes I frame it for caregivers as, are you the good boss right now, or are you the bad boss? And we can go straight to, we will create an intense discipline strategy. Maybe we can get your child to comply, but it's going to be way harder if they don't enjoy spending that time with you, if they don't feel like you're connecting with them, and the timeouts are so much worse in those cases. Doesn't mean that the discipline strategy is easy all the time when even after you go through the first phase of treatment. But if we can get you on the same page as your kid, connecting with your kid better, their compliance is going to be higher, and they're going to just enjoy spending more time with you. They're going to be more inclined to want to listen to what you have to say. So that's one of the strategies I use. Other times I'm like, you've lived with your kids' disruptive behavior for this long. What's a few more months? This is not forever, like you mentioned too. It's like it could be 3 months that we can get through this, but you have to commit to it, and you have to put in the work. Like, I'm not going to sprinkle some magic dust and your kid's just going to be better. I can get the kid to listen to me, but the important thing is, how do we get your kid to listen to you? How do we change that experience and that relationship within your home? Because great, kid loves me, listens to me, but that doesn't change the relationship you have with them. So those are just some things.
I think it's also worth pointing out to parents, like, it took your kid 5 years to get to this point. It just
Yeah,
doesn't get undone overnight. You
right.
kind of undo some behaviors that they've learned or they've been reinforced, and that takes trial and error.
Yes. 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 Yeah, but every parent's different. So like the convincing, sometimes I've got more permissive parents, so they feel like, well, I don't even want to try the second phase of the intervention. It's going to be too intense. So that's a different conversation versus those caregivers that are like, fix my kid now. And you're like, okay, well, we got to do this part first. We got to do this part
But it's also sometimes I feel like it's not just that they want a quick fix or so. Sure, if I had a magic pill, I would, put it in the drinking water.
first.
But they oftentimes they really come at a breaking point. They
Yes.
come at a
Yeah.
point of absolute exhaustion.
Right.
Because it's not natural to go to a therapist or to a psychologist, especially in certain cultures and to certain
Yeah.
family systems. And so they're kind of really
They're
looking for
desperate.
help,
Yeah.
and they're desperate, and there's not much energy left, so that's also where I feel, yeah, you need to give them something. Yeah.
Yeah.
Even
Yeah.
if it's
And I
hope,
think,
or
yeah.
some little strategies that are not punitive or anything, but some little strategies that they can do for now,
Yeah.
that
Yeah.
might alleviate the stresses, and then we get to the more structured approach to
Yeah.
behavior.
Yeah, I think the thing that helps me with some of those families too is, do you want your whole family involved? Do you want advocacy or support in those environments where you're feeling the most stressed? So if it's within the school system or something, and say, I will be your advocate, and then maybe I can work with those, whether it's teachers or the providers, so that we can all be on the same page. And sometimes it's just having like a positive voice that sees the strengths of your family when they usually don't hear that, that also can get them to buy in too.
And
So like,
sometimes it really is,
yeah,
okay, if the school calls me to pick up my kid one more time, I'm going to lose my job.
right, right. And so it's like, can we get a way that, and unfortunately, sometimes they wait until the school's like done. So then you have to
Yes.
have a conversation of like, okay, well, are there other options for schooling? What are the support looks like? But those families are usually so stressed out on many ways that you're also trying to, it's like, okay, well, this is another thing you can do, but do you have the capacity to do this thing? So maybe sometimes it's problem solving, like how do we create support, especially for our families of autistic kids, that people just are more, they're inclined to give them more to do. So how do we help you be the best version of yourself. So this is not just another prescription for you to fill,
Yeah,
that you don't have the capacity for, you know?
yeah.
Yeah. Yeah, these are great points though. 100%, you are not alone. A lot of families, I worked with a lot of families like this. So other things that I wanted to mention too were just some common issues that arise when working with autistic kids. So sleeping, anxiety, toileting, eating, disruptive behaviors are really some of the things that I've seen a lot. This is not an extensive list, but just some of the most common things that I've seen when working with families. So I just wanted to talk a little bit about what some of these things look like, and then talk about how, maybe we address these in therapy too. So the first thing I want to talk about was sleeping. So it depends. Again, there's some of these research studies. I cited some of these studies about prevalence rates. It really depends on the sample. It depends on what study is being conducted where. But I've seen as many as 70% of autistic youth have sleep issues. And a lot of the things that families are reporting are getting to sleep, staying asleep, and then trying to get kids up in the morning. So some of the things that I've worked with families on and talked about are common sort of sleep hygiene, right? So do you have a bedtime routine? What does that feel like? I've had kids with medication that, they take medication to help them go to bed. Sometimes they don't. And so, I think a first line that a lot of families try is melatonin. So does that need to be increased or not? Not that I'm prescribing these things, but this is more of a conversation about, hey, what types of medication is your child taking? What could impact sleep, or what could be getting in the way of sleep? If that's something, I've had families that talk about, well, my child takes X, Y, and Z medications before they go to bed, but they're still having a hard time going to sleep. So then maybe do we move the medication up? Or do we move the medication at a different time, right? And would that help with sleep a little bit? Also thinking about rules about staying in bed. So there's sometimes you work with families and you're like, did you ever just set the expectation that your child has to go to bed and stay in bed at that time? Has that ever a rule? And some families will just say no. And you're like, okay, well, let's just try that. And then the kid stays in bed. And it's like, wow, just having a conversation with your child about those expectations sometimes is all it takes. And then can we provide rewards or some sort of structure for positive bedtime habits? So those are just that's not extensive, but those are just some things that commonly happen, and some common solutions for addressing it that I found with families. Anxiety is another really common one. So kind of like what's addressed in facing your fears. So about 50% of autistic youth may have co-occurring anxiety. Again, going to vary on the age of the kid, the sample that you're looking at. But anxiety can often look like defiance and anger and rigidity. It can lead to meltdowns. So this is different from a tantrum. A tantrum would be like, I want the sucker, and a parent says no, right? I'm throwing a tantrum because if I throw a tantrum, then maybe I'll get the sucker, right? That's different. Meltdown is like, I am overwhelmed by my environment. I've held it together as much as I can, and now I'm not in control of my body or my emotions anymore. So anxiety can kind of build up in autistic kids too. Something can happen and it just can lead to a meltdown. But a lot of these things can look like defiance, but they're not necessarily defiance. So things to think about are relaxation strategies. I think a really common thing that I talk about with families are opportunities for decompression or stemming. So what we know with autistic children and autistic individuals in general is that a lot of them use their body or their environment in many ways to help them manage the sort of overwhelming sensations of the environment. So how do we incorporate those more into our day so we're not feeling overwhelmed by the anxiety that we're experiencing? Anxiety can also be, like with many treatments, by doing exposure too. So how do we expose you to the thing that's really scary and realize that you can handle it and you're brave? But maybe some of those things require it requires buy-in, but also maybe there are other coping strategies that they can utilize to feel like they can handle those things too. So yeah, anxiety is very common. Eating is also a big issue.
Can I
Oh, yes, please go ahead.
I hate to take up so much time,
Oh,
but
that's fine.
what's that one thing I found interesting? So you would use the self-stimming behaviors, you would allow them or even encourage them so that they can use them to self-regulate rather than trying to minimize or eliminate the self-stimulatory behaviors?
Absolutely. Yes. So I think previously the conceptualization was
Yeah, exactly.
um yeah, it's not desirable, right? It looks
Yeah,
weird.
needs to go
Yeah,
away. It's
right.
awkward,
Go
it's
away.
odd, it makes them stand out more. It's not functional. Yeah.
Yeah, and it's not functional maybe to a neurotypical individual, but for autistic people, what we do know is actually it helps them regulate their bodies. So they have
Mhm.
naturally created a way that helps them manage sort of the overwhelming nature of a neurotypically designed world. So, and a lot of our autistic kids have a really hard time with smells, with the fluorescent lighting, with textures. Like a lot of the autistic youth we interact with are like, I can't stand any clothes that have tags on them. I refuse to wear zippers, right? And so they've figured out a way to manage those overwhelming sensations, and the stimming behavior actually helps them. Now, it's going to be a problem if their stimming behavior is like picking at their skin or banging their head, right? We would need to have a replacement behavior for that because it's self-harming. We're not gonna let a kid just
Yeah, but for
bang their head all
example,
day. Yeah.
iPhone, cell phone. I have a client. I mean, he's a young adult, but he's in a program where they don't allow them to be on their phones.
Mm-hmm.
Now, what he does, he has a lot, he's into superheroes. He has lots and lots of pictures of superheroes. And he has them all saved on his phone. And when he gets upset or frustrated, he just gets out his phone, he just scrolls. He goes like that and he looks at his superheroes.
Mm-hmm.
And in the program, he's not allowed to do that.
Mm-hmm.
Um, because no
Mm-hmm.
phones, because it's a distraction.
Mm-hmm.
Um, it's not that he goes in the phone to play a game or anything. It's just looking at these pictures is kind of calming. So how
Yeah.
would you approach that?
I think if you're not allowed to have a phone, it's just problem solving with how do we get you access to photos of things that make you feel calm. So
You
it's not
carry
that's not
around the
necessarily like
phone.
a stemming, it's like a relax that feels more like a relaxation. It's so I would think of like, can we get a booklet of things that you're allowed to take with you, or like a tiny thing you can put in your pocket and like look at photos and print those out. It takes a little bit more time and kind of energy to create something like that.
Yeah,
But if it works for him functionally, then and he's
I
not allowed
think
to
it
have a
would.
phone.
I think
Yeah.
it,
Yeah.
yeah.
That's an example of something that it's not hurting anybody. Also, depending on where kids are, like we have now there's this state requirement in a lot of schools where they're saying kids can't have phones at all during the day, or kids aren't allowed to wear headphones, right? And so we've also talked about having IEP meetings where we have discussions about can this be part of the child's plan where they're allowed to access these things. Now, a phone might be distracting in other ways, but like headphones, for example, like the kid needs them in order to be present because they're otherwise overwhelmed by their environment.
Mhm.
That's just something else to think about.
Mhm.
So yeah, but if people don't like it, that's not the reason not to allow a child to have it, especially if it allows them to be more present in the classroom. So yeah, something else to think about. Okay. Eating is also a big thing, and I recognize we have a few minutes left, so I'm going to try to get through some of these last couple slides quickly. Eating can be a really big problem. For autistic kids, it could be limited food preferences, fear of trying new foods, defiance when presented with new foods because of the sensory overwhelm related to it, and then problems associated with like a medical disorder like gastrointestinal problems. So we can provide reinforcers for trying new foods. We don't necessarily have to force a child to eat everything on their plate because our autistic kids may just not eat them. But if there's really big concerns about like their well-being or their growth over time, then maybe that's also recognizing that working with someone like a dietitian, right, or an occupational therapist that can help them manage some of the unique sensations that they have to do. But can we provide positive reinforcers for trying some things and new things, right? So those are some on the behavioral side and the family intervention side, recognizing as a family, what can we do? Maybe I'm not going to be able to tell a kid whether or not they need like a supplement, right? But I can help them, help the family sort of problem solve. How do we encourage our child to try these new things? Or what can we motivate them? How can we motivate them to try new things? And then toileting can also be a really big issue. So a lot of kids can that are on the autism spectrum may have issues related to sensory input, right? There's a lot of issues with like nighttime enuresis, constipation, and some of this is related to different factors, like individual factors of the child, like language delays are sometimes associated with toileting issues. So again, kind of like with eating, how do we provide positive reinforcers for these? I think sometimes it's like, okay, if you go to the potty, you get to watch your preferred show on the tablet, right? So how do we encourage kids to try these things? And sometimes it's just a matter of like, again, brain signals and body signals aren't quite connected as well. So it's not like because I am purposely trying to avoid this, but rather I don't even realize what's happening with my body. So getting into a routine and trying that, providing some sort of positive reinforcer for then getting into that routine and trying it, et cetera, can help with some of that stuff too. So those are some common solutions. And then the last topic in terms of common issues that kind of co-occur that I want to talk about was disruptive behavior. Again, about 50% of autistic youth can display disruptive behavior. This is going to depend on how you describe disruptive behavior or define it. This can include things like aggression, though, defiance, inattention, hyperactivity is commonly described by families, or self-harm, like I mentioned, in terms of like stemming behavior, like head banging, biting, scratching. So one of the things that I found really useful and I think is really cool, and I want to do some more research on, is having that connection between the parent and child, like what we do in PCIT in that first phase of the intervention. Sometimes that's all it takes, because sometimes the parent is not cued into what the child is trying to say, right, to them, whether it's words or not. And so when they get better on each other's level, right? Or when the parent is better able to reinforce those positive things that they want to see, sometimes that's all they need. It's like this shared communication really promotes enhanced compliance and reduced defiance. And sometimes it's setting clear boundaries or limits. Sometimes it's psychoeducation. So again, people misinterpreting disruptive behavior or disrespect, right? When really it's the child is feeling overwhelmed or having sensory sensitivities to their environment. So again, how do we reduce the likelihood that they're feeling overwhelmed, increase stemming behaviors within those contexts? That can be useful too. Okay, last couple things I want to say. So other things to think about that are really important are just educating everybody in that child's life about autism and unique experiences of autistic individuals. That includes not only parents, but other people in that child's life. I work a lot with schools. Another component that's really important is understanding behavior. So what is driving this behavior? It's not necessarily just non-compliance, right? There's a lot of reasons that kids can do a behavior and it all looks the same potentially, but the reasons for it could be very different. So understanding what the drivers of that behavior could be, and then how do we alter the environment so it's not being a problem for that kid. Also really important is parenting techniques. So how do we problem solve? How do we reinforce? How do we be consistent with the ways that we're interacting with our kid and the expectations that we're setting? And again, making sure they're developmentally appropriate for that child. Working with schools is really common. So a lot of the families will come in because either the school has stated that they're having issues with the child, or because the caregivers are worried about how the child is doing within the school system. So advocating for that child within the school, attending IEP meetings, helping construct behavioral plans. I've had really great success in some schools, and I've had really terrible experiences in other schools. And so sometimes it's also the conversation of like, are there other options besides this school if the school's unwilling to work with kids? And this happens depending on resources available at the school system within the state. So something else to consider. And then another important part is a lot of autistic kids have a lot of interventions. So especially if you're working on sort of overlapping concerns that other providers are addressing, let's make sure that we're being consistent. We're not telling families one thing in one setting and telling them something else in another. And now our interventions are not aligning very well. So being consistent across across care means usually you're going to have the caregivers fill out ROIs. You're going to communicate with those other providers and make sure everyone's on the same page. So last comment that I wanted to just have was if you're interested in working with autistic individuals, think about how to attend some trainings, think about consultation. I'm always happy to chat with folks if they've got questions. How do you invest time in understanding the experience of autistic kiddos? And that's all I've got. So thanks, everybody. I realize it's right around 1 o'clock and I want to make sure you get to your next thing that you need to, but feel free to reach out to me if you have any questions in the future, and I'm happy to chat.